Good afternoon, everybody, and thank you, Gaurav, for having me on your course. I've got no financial disclosure related to this talk. So as you know, the Malyugin ring is a square-shaped polypropyl ring, but it does not only provide 4 equidistant spots of dilatation, but it provides 8 points of fixation. So that's where, like, it's between the scrolls also, where the part of the ring which is going across the pupil margin, it provides that fixation at that point. So it's an 8-point fixation, not a 4-point fixation. It can be inserted up to 2.2 millimeter inside, and you can go inside the anterior chamber and then put the ring in. It normally comes in 2 sizes, 6.25 and 7. So the point which one of the ladies were raising, if you are worried about complication, if you are worried about where you might need to convert or other things, a 7 millimeter ring might be a better option than a 6.25 millimeter ring. The pupil, if it's smaller than 3 millimeter, then you should provide a gentle dilatation and make sure the anterior chamber is not overfilled. But you need to put in viscoelastic. So that's my first video. So we need to load the ring. It comes in a preloaded injector. You load the ring and then only you separate it from the injector system. This is a pseudo-exfoliation patient, as you can see. So you can put the lower scroll down first, and then the 2 side scrolls can also be easily be put in with the same injector. If you're not able to put the 2 side scroll, that's not a problem. Then the 4th scroll is usually put by using, I use now a washer hook, which is a great instrument. Once you put the ring in, you need to center it, so you need to pull it back. In this case, as you can see, there is a bit of zonular weakness over there. So once we have done the IA, I use a silicone tipped IA in most of my cases, which has dropped our complication rate for IA quite a lot. And then we put the CTR in. And then once we put the CTR in, you can put the lens in. And then basically in any ring expansion devices, putting in is important, but removing the ring is equally, or I think it's more important. That's the more trickier part. So you remove the lower scroll down, then the 2 side scrolls. Then you need to the upper scroll, and then I use most of the time injector, because this is the most neatest way of removing the Malyugin ring. If you don't use an injector, you can do it with other ways also, which I will show you during my talk. So this is my second pupil. It's a small pupil, as you can see. So what you need to do is put in viscoelastic, try to dilate the pupil. I said 3 millimeter or more, then you will find better use of the Malyugin ring. Put in viscoelastic both behind the iris and in front. What you don't want to do is damage your lens capsule while putting the ring in. Once you have put in a viscoelastic, and this is a technique which I have developed, like if sometimes in 2.2 the injector does not go, so you put the injector upside down and then rotate it. Once you rotate it inside the eye, it goes well, and then you put the ring in, the lower scroll down, and then put the 2 side scrolls, and then always use a second instrument like a washer hook to put the 4th scroll in. And then basically once you put the ring in, what you need to do is basically take the washer hook, pull the ring back and center it. This is very, very important point. Otherwise the ring is, because you're pushing it down, it always a bit decentered. And then you can continue with your surgery, whichever way you want to do. I do a direct chop. You put a lens in, and then remove the ring. Like you can, as I said, like in ideal situation, you pull the lower scroll out first, but you can pull the upper scroll, side scroll, till you are doing it in a gentle fashion and one by one. And once you've removed all the scroll, you can then remove it. Always stabilize the ring in the anterior chamber. So put in viscoelastic behind and in front of the ring. So once the ring is stable in the anterior chamber, then put in. Sometimes if you see, what can happen is the ring, it does not go in. So what you need to do is that scroll gets stuck. So you go in with the second instrument and basically tuck that scroll into the injector system. And then, but you don't need to completely withdraw the ring also. You can sometimes just withdraw it partially and then take out the whole ring out also. So this is a uveitic cataract with posterior Synechiae. so these are type of cases which are difficult sometimes. So in these cases, first you need to separate the posterior Synechiae. So go in with your viscoelastic and try to separate the posterior Synechiae from all around. Make sure you go in from the side port also, so that it is 360. And then you put in your ring gently, lower scroll in, and it will engage above and behind the RS, and then the two side scrolls. And then with the second instrument, put the fourth scroll in. And then you can continue with your surgery, pull it back. And sometimes like what can happen is as you can see in this case, what's happened is the side scroll, if it does not go, then you might have to literally pull on the bar of the ring to get that scroll out, because if the pupil is small. So you can do that with the Osher hook, try to pull on the bar, push on the bar, and then put your scroll in, because sometimes if the scroll goes behind the iris, that can occur. And then it's very difficult to manipulate. So in that case, the bar acts as a good leverage point where you can pull that scroll out of that. And then basically, you can, as I said, like there are other ways of taking out the ring out. You can try, you use a hook up. But the problem with those techniques is what happens, see what happens. The scroll sometimes can get stuck in the wound or behind the iris. So you have to be very, very careful, and you should always watch the trailing scrolls. It does not come out as neatly. As you can see, the scrolls are getting stuck onto the iris. So using the injector system to take out the ring back out is the best way of doing it. And so this is another video. If you see removal with scroll, if it's not correctly engaged. So we put the ring in as normal. And then if you see, if the scrolls are not engaging, what you can do is you withdraw and then put the scrolls back in. So you complete your surgery whichever way you want. We put an aqueous lens over there. And then basically remove the ring. Always remove all the false scrolls before doing anything more to the ring. Stabilize it in the anterior chamber. Put viscoelastic behind and in front of that ring. And then if you see, if it's not engaged, see what's happened. So if you don't put your hook over both the scrolls, and if you just put it over the lower scroll, then the ring twists. And if the ring twists, then it can get caught in various places. So this is a small video where you can remove with the forceps also. So you catch hold of it, and you can try and pull the ring. As I said, the injector system is the best way of removing the ring. It's the most neatest way. And if you use a side instrument, then it is. The other important point is if the ring is not correctly loaded, that means while withdrawing the lid, if you remove it before if it's completely loaded into the system, then the ring can come out damaged. So like in this case, if you see, we put in viscoelastic and see if you see what's happened. The ring is damaged over there. You can see how the ring has come out. So it's completely damaged because the injector was pulled before it was completely loaded. But if you try to put this ring in, so for example, like if you see what we are trying to do is, okay, one or two scrolls are damaged, we'll try to put it in and see if it goes well. What happened in between the surgery, the scrolls come out and it does not do well. So then you have to remove the ring in between the surgery to do that. And then this is the worst case scenario for the Malyugin ring. So this was a patient with atrophic RS. We have done the case, we are trying to remove the ring, and the problem has occurred because what we have done is we have engaged the lower scroll only, we have not engaged the upper scroll. It was an atrophic RS, you can see there is a lot of transillumination, and what happens is the ring rotates and twists. And once it rotates and twists, it goes through an atrophic part and it gets caught into the iris. And what happens sometimes when your mind is over there, you don't see what's happening to the distal scroll. So that distal scroll gets caught into the iris, and then you're trying to separate it, and it's not coming because the whole scroll is gone into the iris. So you've got a big iris defect now over there, and then you basically try and implant the ring into the anterior chamber to separate it from the iris. and then basically take it out. So this is a worst case scenario. It's not happened more than once, I can promise you that. And that's what, so we sutured that defect later on. And this is a recent case which we did. So even in cases with Fuchs and mature cataract through the exfoliation, you put in vision blue, you expand the pupil, go in from the side port, load the ring properly. So once it's loaded into the barrel, then only separate it from it, put the ring in, and then you can go ahead with the surgery. So this is just a small animation which shows exactly how, it's a 4-scroll ring which goes all around, and basically you need to load it properly and then go along with it. It's a wonderful device because you don't need to make any more side ports. You're not worried about anything else. It's a very quick procedure also. Once you have used a couple of these, it's very easy to load and to take out if you follow the correct procedure. So that's the loading. Once it's loaded, then only separate. And that's where like the lower scroll goes behind RS and on the sides. And then you use a second instrument to put the 4th scroll in. So basically, these are the advantages, as you can say. You can go to 2.2 or even smaller. Floppy RS, it's much better, and it does not interfere. You can use a larger ring. But I feel this is important. The retraction is the most trickiest part of the ring and more important than insertion. And most problems happen during retraction, not during putting the ring in. It should be done after putting in the IOL, but before removing the viscoelastic. Always remove the distal scroll first and proximal. Stabilize the ring in an anterior chamber. And then, if possible, always use an injector to retract the ring out. Because that's, as I said, I showed you in a couple of videos, that's the most neat way of getting the ring out. So those are the tips and tricks which I've already discussed with you. Thank you.